Most respected Manchanda madam, and the audience. I would have loved to be there, but unfortunately I triple booked myself on this day. In one in Bangalore, one in Indore, and one in Mumbai. And Bangalore people were very happy to accommodate me the previous day, that's yesterday. But Indore people were totally unrelenting. So obviously I had to make this presentation online. So my job is basically to tell about the science that's developing in cell counter. Cell counters are hemocytometer, and their science is going into something like cytology. So therefore, I would say not only hemocytology, but it's an objective way of measuring hemocytology. It's hemocytometrology. Science is defined as the observation, identification, description, experimental investigation, and theoretical explanation of natural phenomena. A hematology analyzer is primarily to count blood cells with some degree of differentiation based on mainly physical nature in natural form or distorted, and a few by chemical reactions like fluorescent dyes. We know our cells and more, probably a little more, because of Romanowsky dyes. And in fact, hematology is defined by Romanowsky dyes because neutrophils are called neutrophils, because eosinophils are called eosinophils because they stain by eosin dye, and basophils are called basophils because they stain by the basic dye, and provide explanation for the natural phenomena that is there. We presume that analyzers are also seeing the same we are seeing, but maybe better, most likely better. The interest now is to predict how much it sees and is able to explain the natural phenomena. Many of these natural phenomena are well understood, and now the cell counters have to identify, observe it, test it, describe it, till it becomes a testable explanation of the natural phenomena. Impedance, the basic heart of the Coulter principle, and of course adopted by most of the cell counters, especially the 3-part, has got immense accuracy. There are particle counters which can measure up to 1 nanometer in size. No other machines can do that. Nothing so far is better, but morphology is not like what we see. So a testable explanation needs more explanation. So now when we come to 5-part platforms, we must realize that many of the cell counters process the cells as they are being analyzed. So obviously it has got a lysis, which can be of a different type of lysis, which can impact the white cells, which are going to be differentiated based on some of the characteristics. Some of the white cells are still maintained in near native state. Some lose cytoplasm to allow dyes to enter them. So, but you must realize all the analysis that happens, irrespective of processing, is happening within a very, very short time. We are talking about a few seconds, about 30 to 40 seconds. And the impact, how much of the impact of the distortion of morphology impacts on the morphology of the cell. Then finally, after all that processing, look at the signal destination rather than the light source. Don't look at the light source, look at the signal destination. That's a photomultiplier. And therefore, the analysis is to discriminate based on physical attributes of the cell. Now it's purely physical attributes. Size, yes, because they maintain the size, there is no loss of size. Can be possible on DXH, alinity, Umicin, and indirectly on Advia. Fluorescence on XN, BC, and alinity. Staining and light loss on Advia and Umicin. Nucleocytoplasmic content because of the the high radio frequency current is DXH, but granularity in all the cell counters, directly or indirectly. Now DXH, of course, we know that along the x-axis you have got scatter, that is the granularity. Along the y-axis you have got the size, and along the z-axis you have got the nucleocytoplasmic content. XN and BC, along the x-axis is scatter, along the y-axis is fluorescence based on the nuclear staining of the dye, the fluorescent dye. And of course, you have the basolysis where the cells are exposed to very low pH lye solution, where only basophils, which have got probably the pH of 1, because it contains heparin, survives the lysis, and they get counted because of the size, which is along the y-axis, and that is the size. Then you have Umicin and Advia, which looks at staining of cells. They use a stain which basically stains the myeloperoxidase. Of course, straight away myeloperoxidase by Advia, and similar like myeloperoxidase on Humicin. But along the x-axis is basically on the Humicin is on the light loss. The size, and along the y-axis is the light loss. While in Advia, along the x-axis is the absorbance. That means the more the absorbance, that means more peroxidase staining. You have the cells coming on the x-axis, and along the y-axis is purely light loss. They also use the basolyse to differentiate basophils. Alinity, probably all the existing platforms have been building on the hardware which is same, and using the software they have been trying to develop new parameters. Alinity is, Abbott or Alinity is the only cell counter which has probably changed the hardware. It has changed a lot of photomultiplier tubes, and they brought in fluorescence in analysis of the white cells, and therefore they use size, scatter, and fluorescence to differentiate between the white cells. And of course, they did not want to sacrifice their MAPS technology. Now we know that we have suspect flags, but we also know that these cell counters analyzes the cells 360 degrees centigrade. Many systematic diseases bring changes in white cells, red cells, and platelets. Unfortunately, these changes are also reflected within the gating of the white cells, but there is no flag. So obviously, we'll have to look at how they can develop flags. Some of them can be used by cell population data, like for example, the VCS has been always having cell population data, but now more cell counters are giving cell population data. Only thing is you have to get a reference population and do your cell population data, and you'll know what is the average size of neutrophils in a population, what is the average size of lymphocyte, what is the average scatter of a neutrophil, what is an average conductivity of a neutrophil, what is the average fluorescence of a neutrophil. All that you can find out by using a reference population. And if you have a blood bank in your hospital, obviously you have healthy blood donors, you can use them. A new parameter has been, a lot of new parameters are being developed. Like for example, you have MDW, which is considered to be a person value which has got a highly negative predictive value for sepsis or acute bacterial infection of 98%, along with white cell count. So these are some of the new parameters coming from the cell population, which is from the scatter. Now, when you talk about sepsis, we always talk about toxic neutrophils. Obviously, toxic neutrophils, when you look under the microscope, has a lot of granules. So they thought that probably there may be more scatter in these neutrophils. And there was a study that was done by Fernando Chavez, who is now the medical director in Beckman Coulter. And he found the study in which he revealed that consistent finding in sepsis was that the neutrophils were large in volume, large in size. What they underplayed was the fact that actually the scatter was low. They actually thought the study will show more scatter, but actually the scatter was opposite. It was low. We must understand that they were confused why that happened. If you understand normal physiology, you will understand that from a myeloblast to a neutrophil takes 5 to 7 days, and the 4 changes happen to that. The blue color of the cytoplasm becomes gray because the RNA gets converted to proteins. The nucleus becomes smaller, then segmented. And then the granules start appearing in promyelocyte, metamyelocyte. But by the time it comes to metamyelocyte, they lose their staining property because they mature, because the granules contain sialic acid. And as they mature, they lose the sialic acid and they stop taking up the basic dye, the azurophilic dye. So the granules are very much there. Only thing is they don't get stained. And of course, the size of the myeloblast becomes almost half. But when there is sepsis and when there is acute bacterial infection, this maturation of 5 to 7 days can happen in less than 1 day. That means the nucleus will go all through the segmentation. The granules do not lose their staining property, so they start appearing more. They start appearing to be more because they take up the staining dye, the Romanowski dye. So it's purely a normal. What we talk as toxic granules is nothing but the same granules, but they don't lose their staining property. It's a Romanowski phenomenon. The blue color completely does not disappear and they remain as Dolly bodies. And the size of the neutrophil does not, the size of the neutrophil does not become as small as normal. It becomes large. So large neutrophil, toxic granulation, Dolly bodies, they are all indicative of a neutrophil that is produced within less than 1 day of maturation, which basically means it's a acute bacterial infection. The study that we did in Vellore, which was done in about 12 years back, but published in 2016, we also brought in the fact that not only the neutrophil volume is high, the neutrophil scatter is low, we also found that the monocyte volume was also on the higher side compared to ICU controls, the patients who are admitted with hanging or poisoning. It was purely on the monocyte volume also was much higher compared to them as well as blood donors. Now, if you look at this cell counter plot, you can realize that when the neutrophil becomes large and their scatter is low, they slowly start merging with the monocyte. And therefore, the monocyte distribution will be wider, either because of monocytes being there or some of the neutrophils being counted as monocyte. So this is called a pseudomonocytosis. So pseudomonocytosis of a cell counter is one of the earliest indication of sepsis. How do you identify that pseudomonocytosis? If you look at the histogram, after the lymphocyte, there's hardly any monocyte. What you see there as a peak is actually the left shift of the neutrophils. So if you have a histogram, you can easily identify the scatter plot or the monocytosis as pseudomonocytosis. So MDW is nothing but pseudomonocytosis. Of course, we realize that monocyte also contributes in addition to neutrophils into the cell counter data for identification of sepsis. It is potentially possible in all cell counters because when the sepsis happens, as you look at the lower spot, the neutrophils will have larger in size, will have lower scatter, and they will slowly start merging into the monocyte population, and monocytes will be exaggerated. Even in alinity, you can see that the monocyte and the neutrophil populations are merging, and therefore you can have potentially of pseudomonocytosis here. So how do you identify the monocyte count is true or pseudo? If you just look at the WBC histogram, you can see that if there is true monocytosis, you can see a peak at the WBC histogram. Both the histograms below, you can see that. Now, the previous case I showed you, you can see that if there is pseudomonocytosis, there will be no peak and the monocyte. That basically means the monocytes are being falsely counted because they are counting neutrophils as monocytes, and therefore pseudomonocytosis is a very important part of sepsis. So you must realize that cell counters will only tell you what it can analyze. In fact, we have Dr. Swati Pai there. She's the king of pseudo because she called eosinophilia as malaria, pseudobiophilia as dengue. If she had identified pseudomonocytosis, probably should have identified pseudomonocytosis for sepsis much earlier if she had probably collected data on that. Now you must realize that other cell counters where cells are not important, size is not important. If you look at the fluorescence data on the on eosinophils and probably and on Sysmex as well as on Mindray, the neutrophil fluorescence is very high during sepsis. But in the whole thing, you must realize that there is a very important and simple parameter called eosinophils. Eosinopenia is probably the earliest indicator of sepsis more than any changes that happen on the neutrophils. And you can see in the study that we did here, the eosinophil population in patients with sepsis was 0.1 compared to the people who had non-sepsis 0.6. Now you must realize that whenever we take the reference range for eosinophils, we always talk about 44 to 440, which is the reference you can see in Daisy, in Hofbrand, and all those things. They are all, they don't belong to us. We should have our own reference range. The reference range that we developed was 0.2 to 0.6. Please understand, the difference, the eosinophil reference range is different from different population. We can't use 44 to 440 at all, because which is 0.4 to 0.44. If I had used that reference range, I would have probably missed, 0.04. I would have missed diagnosing sepsis using eosinophil count. You have to use your own reference range. Similarly, for monocyte, everybody talks about monocytes. All cell counters exaggerate monocyte count. We have tuberculosis in our population. Even people who don't have symptoms, they have tuberculosis in the population. Please don't underestimate your, so please use your own reference range. If you do use the reference range that is available from outside, from Daisy or whatever country, you will lose a lot of patients or a diagnosis on a lot of patients. So please don't say that this cell counter gives higher monocyte count. It is absolutely wrong. Of course, the high neutrophil fluorescence because of Dolly bodies. I'll give you an example how I use this data. 70-year-old retired, highly reputed professor of CMC undergoes a resection of colon because he had a CF colon with anastomosis. He spikes fever on day 4, CRP is high, and the surgeons think it's anastomotic leak. Yes, usually happens on day 4 or day 5 of surgery, post surgery. Now, if obviously the response is they have to take him for re-exploration, morbidity is on the higher side, and if you don't take him for re-exploration, and if it's an anastomotic leak, mortality is going to be high. So when they decide to take re-exploration, the surgical ICU consultant asked me, can you probably look at the blood film and say whether it is, because obviously an anastomotic leak will be active bacterial type of infection. Can you say that this is bacterial or non-bacterial? His white cell count was higher from day 1 itself. So this is his scatter from XN. Here I can find that neutrophils looks absolutely calm. The count is high, neutrophil count is high, but they look absolutely calm. They are not having any higher fluorescence. But when I look at the lymphocyte, I can find there are few reactive lymphocytes. Now, before I give an opinion, I know that we have this reactive lymphocyte which can be quantitated by some of the cell counters by high fluorescent lymphocyte, high fluorescent cells, atypical lymphocytes, like that. So when I looked at the value, the HFLC was 1.6. Yes, there are reactive lymphocytes. But before giving the opinion, I thought I'll run the sample on another cell counter. And when I ran the sample, okay, fine. The neutrophils look very calm. There is some reactive lymphocytes which are merging with the monocyte population, which is quite good to know that there are reactive lymphocytes. And then what I find that, okay, now that they say the MDW is indicative of acute bacterial infection, I found that it's less than 23. So therefore, I'm very confident there's no bacterial part at all. So I give the opinion that this is not bacterial at all. It probably could be viral. The registrar calls, the junior consultant calls, the senior consultant calls, and there's a retired surgeon from our place who came to help with the surgery because this guy was so senior. So when he called, I said, it's not bacterial, but viral. And his wife was my colleague. She retired many years back. So he said, are you sure? I said, only your wife probably taught me this. So he accepted my opinion. No re-exploration was done. This gentleman recovered and discharged on day 11 from SICU. Otherwise, they would have definitely taken him for re-exploration, where the morbidity would have been much higher. When we talk about an iron deficiency anemia, we have been told that iron deficiency is microcytic hypochromic anemia with anisocytosis. Look at this picture on top. How many of you can say that these are microcytic red cells? If you say that this is microcytic red cell, next time when I give you the same blood film, you will call it as normosity. Size is subjective. But what is very objective in this is the color. Anisochromia is probably the most catching point of iron deficient erythropoiesis. And this, actually, I learned this from a cell counter because it's some cell counter which is called as hemoglobin distribution with percentage hypo, and therefore they give you anisochromia for a diagnosis of iron deficient erythropoiesis. CHR or the equivalent, that is RET-HE or RHE, is probably the lower CHR or lower RET-HE is an earliest indicator of iron deficient erythropoiesis. The earliest. Nothing can be, not iron deficient anemia, but iron deficient erythropoiesis. And when the patient starts on treatment, the response can be seen in shift in HCW. And all this I learned from a cell counter. Now, obviously, some cell counters measure the hemoglobin content of the red cell on the reticulocyte based on the my algorithm, based on very precise catching of low scatter light from the red cell. Some of them, of course, don't have that ability, so they actually use calculation to. So CHR is calculated. It's measured by ADVIA as well as by Alnity. While the equivalents are produced in RHE, RET-HE, in Sysmex and Mindray. and therefore they are calculated parameters. Mindray does have a equivalent of CHR, but I found that not at all reliable. But RHE of Mindray is much more reliable, and I'm very happy that there are some talks related to RHE and RED-HE, because I found these parameters quite useful in my clinical practice. I'm very happy that there's only one talk related to IPF. So thanks that people have realized that IPF was probably not the right parameters, because nobody talks about immature platelets, because we never talk about mature platelets. So why we talk about immature platelets? So I'll tell you how I use calculated parameter in my clinical practice. One of my colleagues who was having chemo, also iron deficient, her hemoglobin dropped to 5.4. She's undergoing chemo. So she's on iron. Her MCV is low. So when the husband said, we're coming to hospital to take you, can you organize 2 units of Paxil? I said, oh, no problem, I'll organize that. So I looked for Paxils which have got good hemoglobin content. And because I had a hospital number, I took her peripheral smear, and I found that the peripheral smear had hypochromic red cells. Yes, she is iron deficient with mild anisochromia. That means there are some red cells which are normal hemoglobin, and a few of the red cells were well hemoglobinized. But when I looked at the reticulocyte, the polychromatophilic red cells, they were really well hemoglobinized. That means the reticulocyte hemoglobin content was good. Obviously, she is responding well to iron. So I thought I'll look at the RED-HE, because when I look at the smear, I know that the CHR value is, reference range is 33 to 35. Now, I'm not sure whether these well hemoglobinized red cells are 33 or 35. If I can confidently say that 35, that means there's a better chance. If I can confidently say that the 33, okay, come and have your transfusion. But I can't say that, because morphology, when normality can be between 33 and 35, it has to be that. I can't say that. So therefore, I decided to look at the RED-HE, and the RED-HE was 42. It is not possible by any morphological event, even if it is calculated parameter. 42 was magical. I called them and I said, do you really want to come for transfusion? Can she, if she's is she really unwell? If she's just tired, just give her bed rest for 2 days. Anyway, we are going to repeat the hemoglobin 2 days later. Her bone marrow is doing a fantastic job. She's producing red cells, where the red cells have got phenomenal hemoglobin. So, normally all these parameters, everybody uses RED-HE, RHE, CHR. When we're talking about iron deficiency, here we are talking about iron repletion. And I could tell them not to have transfusion. Why do you want some of the people who are close to you have blood transfusion? Blood transfusion is risky. So we avoided a blood transfusion in this lady. And, the next 2 days later, of course, I didn't sleep for the next 2 days. The 2 days later, hemoglobin was 8.4. They actually, the husband and wife still call me magician, because I prevented 2 blood cell transfusions. So you must realize that cell counters do not hide anything. It is the individual who has the cell counter that gets masqueraded. And they get what you call unnecessarily involved by the pseudo, which actually indicates a possible diagnosis. A cell counter gives the output that represents complete analysis of the cells in the blood. Understanding of the disease process well, which is a pathology, we get to realize the same is clearly displayed and objectively measured by the cell counter. This understanding, if translated into patient care, can overcome many deceptive clinical scenarios. Of course, more studies by good centers will make this more impactful, and times to come. Thank you very much.